Good afternoon and welcome to Exploring and Evaluating Healthcare Data Archival Methodologies and Strategies, a webinar tweet chat combo from healthsystemcio.com, sponsored by Galen Healthcare Solutions. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemcio.com, and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our managing editor and director of social media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can simply view the tweet chat in the media viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel today. When you have a question that occurs to you, type it into that box, leave the default set to all panelists, and send it in. We will be taking those later in the program, but again, send them in as they occur to you. And you could download the deck using the URL on your screen. It's at the bottom of some of our slides, and it also is being sent out in the chat box. Just so you see how we're going to spend our time today, first we're going to go about 40 minutes with Robert Downey, VP of Product Development with Galen Healthcare Solutions, and then we're going to have our Q&A with Robert. So without further delay, I'm going to turn it over to Robert Downey. Robert, thank you for joining us today.
No, thank you. So we'll hop right into the content. We've got quite a bit to cover today, and I want to make sure we can get to the Q&A section at the end, leave plenty of time for that. So briefly, the overview of what we're going to be covering, who we are, what company I came from, and then jump right into the real content. So at a high level, why are people archiving versus migrating? Why are people doing one or the other or both? What do we need to archive from a legal point of view and from a clinical continuity perspective? And then finally, the real point of this is how do we archive this data? What are the different technologies and strategies and processes that are used to archive data in a clinical setting? Because it turns out that there's some nuances in the healthcare arena that aren't common in a lot of other spaces, mostly legal related. So as mentioned, I'm Vice President of Product Development at Galen Healthcare Solutions. Full disclosure, we have our own archival solution. It's one of the reasons that I've spent so much time diving deep into this topic is because we built a product around this problem. And my contact information is there. Obviously, if there's any questions or comments that you'd like to send after the fact, after our sort of live Q&A session, please feel free. Go ahead and reach out, and I'll do my best to respond to everybody. So Galen, at a really high level, we're a health IT company with a professional services, technical services, and product development section. We've got 3 offices in Boston, Burlington, Vermont, and Chicago. And we've been around for about 11, 12 years now. We were ranked #1 in class, and this is relevant primarily because a lot of the work involved in archiving clinical information is really in the implementation process. It's getting the data out of the systems and making sure it's accessible legally and clinically. And the #1 in class ranking is relevant because both of those groups, both of those #1 ranked groups, that's what they do. That's most of our business these days is moving data out of these systems and archiving it. So why migrate? Why archive? Why do both? So at a high level, a lot of organizations that we have experience with choose to do both. So let's start off with the migrate side of things. Why do we want to move data, in addition to archiving it, why do we want to move data from one clinical or practice management system into another? Why do we want to preserve that flow of data and keep it and bring it forward into the go-forward EMR and clinical systems, rather than just archiving the whole thing and keeping it in that separate solution? Well, at the most basic level, an EMR is not just a data entry system. It's not just there for raw data entry. It has a lot of other ancillary features and functionality that really don't light up or work in any meaningful way without data. And so if you're leaving behind, millions of patient records in a legacy system, you have to start fresh. It's like you never used an EMR before. And so obviously there's different levels of data migration, but you want to do a minimum that lights up some of this functionality. You want to make sure that your workflows work appropriately, that things like clinical decision support and analytics that are fed from the go-forward EMR light up as you'd expect them to light up, and that functionality works. And really you want to minimize provider disruption as a whole. The last thing you need is for providers, when they're moving from a legacy system to a new fancy EMR, to feel like there's even more disruption than there's already going to be, because they have to start fresh. They have to re-enter all of the information they'd already entered and already curated in the old systems. And in that bottom right-hand corner there, you can see some high-level stats about some of the costs associated with this. And obviously, data migration is not cheap. Moving data from point A to point B is a time-consuming and technically difficult process. And so the cost of not doing it has to be greater than the cost of doing it for it to be worth it. And it turns out in almost every scenario that is the case. So manual chart data reentry can cost, as you see there, $8 to $30 per chart. You're talking about potentially an hour of work. If you end up not moving that data over, the resulting treatment delays and test duplication can be upwards of $1,000 an incident. And then most interestingly, in my view, is the fact that incomplete chart information in general can result in $96 per patient in cost to your organization. So what does that mean? Well, this is not $96 per patient, that was in the old system versus the new system. This is, on average, that cost spread across your entire organization, and all of the patients is this, because there might be legal challenges that you're not able to answer. There might be, related to the test duplication and treatment delays. There might be misdiagnoses or incorrect prescriptions or what have you because of the lack of that information. So minimizing that while still comparing it to the relative cost of doing the data migration is important. So that's why a lot of organizations choose to migrate at least a subset of the information. So why don't we just migrate? If we're moving data into the new EMR, into the go-forward EMR, why do I need this whole archive thing? Why do we need to preserve other data, and what is that data? So at a high level, and this alludes to this is related to what we were just talking about, when we're moving data into the new system, we're not moving everything. We're moving what's clinically relevant. There's a time range that's relevant. So typically a lot of organizations might move the last couple of years per patient. So if a patient has a 10-year medical history, chances are the vitals from 9 years ago are probably not relevant today. So they're going to move just the last couple of years worth of data. Sometimes you're limited in what you can move based on the go-forward EMR's ability to accept that information. So this varies dramatically from vendor to vendor. Some vendors support direct database uploads. That's not very common, but when that is possible, there's almost no limit to the data you can move in. A lot of vendors will limit it to public interfaces like HL7 or CCD, et cetera. So in those cases, you're limited kind of by the formats and the accessible mechanisms for getting the data in there. So right off the bat, you might be limited to things like problems, allergies, meds, and immunizations, and maybe some document-related data. But there's a wide variety of other data that's simply not going to be coming over, and you can't be missing that from a legal perspective. And we'll dig into some of those details in just a minute. The level of fidelity of those data, of the data that we're moving over, is paramount from a legal perspective. And when we move data from one system to another, there's an inherent change to that data, right? The way that one vendor stores an allergy, for instance, is very different than the way another vendor stores an allergy. Now, the concept and the overall end goal of the allergy is the same. They have a bee sting allergy or what have you. But the way that information is stored, the properties that make up that bee sting allergy, the nomenclatures and codes that make up those pieces of data are different. So when a data migration takes place, there's mapping that happens. And that's one of the things, honestly, that's the most expensive aspect of a data migration, is the fact that there's generally a very manual, very time-intensive, very error-prone, honestly, process of mapping data from one system into another. And when you do that, you've changed the data, right? You've fundamentally altered what the medical record looked like from one system so that it would fit into the new system. And that is kind of the antithesis of what you want to do from an archival perspective. The last aspect is that data migrations in general are limited to what groups consider clean information. We all know that maintaining data in an EMR is difficult from a data curation and cleanliness point of view, making sure that things are entered as you expect them to be entered, making sure that that workflows are followed appropriately, and there's always going to be some subset of the information in the EMR that is just dirty and ugly information that you don't want to bring over, you don't want to pollute your new EMR with, and for that reason and all these other reasons, you're simply not getting a full cross-section or a full selection of the information from the legacy systems when you're doing a data migration. And that's why you really need to be able to, or one of the many reasons why you need to be able to have a separate archival strategy independent of your migration strategy. So what do we need to archive? What is the sort of guiding rule that allows us to look at a particular piece of data in a legacy EMR and decide whether or not we need to store that information in an archive of some kind? And this is what I usually cite. So it's any information that may be used or may have been used to make a clinical decision at a given point in time, as well as any information that shows what and how that care was delivered. And there's a lot of, and I made some bold blue-colored text in there to point out some very interesting nuances in this statement. And that's because if you parse this and unpack it a little bit, it turns out that the way that a lot of organizations handle ROI now when they're using a live EMR is not necessarily compliant with this statement. Being able to print a chart from an EMR and produce that record and treat that as your legal medical record may or may not be following this statement to a T. And if you don't, there's an inherent amount of liability and risk associated with that. And we'll drive into some details of that in just a second. So before we do that, let's briefly talk about some terms that anybody who's dealt with data archival in a clinical perspective has heard, the designated record set versus a legal medical record. So before I go forward, a little side note here, this slide is a little misleading. There were I made some bad edits to this before saying it off. So I want to talk through this in a little bit more detail than what you see on the screen here. So at a high level, a designated record set is a superset of the information that's in the legal medical record. And the primary distinction between these two, aside from the data that makes up these two collections of information, is really the general guidelines for when one is handed off to a third party versus another. So generally, the designated record set would only be handed off to a third party in two primary scenarios. One is when an individual patient, the subject of this information, is asking for that. They can ask for anything that is classified as information in the designated record set, and you'll need to be able to provide that to that patient. Versus the legal medical record, which is basically every other scenario. You're talking about third-party referral scenarios. You're talking about potentially some payer audit or other audit-related scenarios. And then the one that unifies both of these is when you're dealing with an e-discovery or legal situation. They're going to define what they want in that request, and it doesn't really matter what you defined as the DRS or the LMR. You're going to have to fulfill whatever they've defined in their request, regardless. But at a high level, when you're looking at the information that's only in the designated record set versus the legal medical record, you're often going to have some ancillary pieces of information that may not be directly relevant or related to patient care. So occasionally that'll be things like information that informed care but was not specific to the patient. So a committee meeting finding that provided general guidelines for care, and then that was used in some way to inform a decision of care for a patient. That's a good example. Versus the information that's in the legal medical record is essentially anything that is directly related to the care of that patient and how that care was delivered. And so the advice that we give customers when we're defining these terms and helping them build out their strategy is to, when in doubt, archive the information, as long as the way you're archiving it makes it accessible and filterable and discoverable, because the last thing you need is to have a giant pile of data and you're not able to find what you're looking for. But at the same time, the organization needs to have, as a matter of law, needs to have what makes up their legal medical record versus what makes up their overall designated record set. They need to have that documented and signed off on as part of the legal requirements for a healthcare organization. So step one in any archival process, and really this should have been done long before any archival process is even considered or a migration is considered, is to document what pieces of information make up each of these sort of categories of data. So one of the things that I find useful when dealing with archival projects is rather than go through all of the things that we need to document or need to archive, is actually to go over some of the things that are very commonly missed and use those as teaching tools to train people to identify risk. Because when we're archiving information, it's really about mitigating risk. To a large extent. Clinical continuity is obviously a big part of this, and that's oftentimes handled by your data migration strategy rather than your archival strategy, but not always. And so when we're dealing with this, it's really what are we looking at that could expose an organization to risk because they're unable to produce that information in an e-discovery, in an audit, or whatever the scenario might be. So the first one is a contextual audit trail. Audit trails are often ignored in general when you're producing legal medical records and output for third parties. I mean, if you think about when you use an EMR to produce a chart, that chart doesn't usually have an audit trail attached to it. And so it's oftentimes just ignored when we're talking about producing ROI. And so when I say contextual, I mean more than just a raw list of who did what and when and to whom. It's really the ability to trace that audit entry from a legacy system to the individual piece of information that it's talking about. So if the audit entry was, I edited a result, or I added an annotation to a document, or I signed a note, being able to go right to that note and be able to trace that audit information to that individual piece of clinical documentation is often the difference between a successful e-discovery and a successful legal challenge and not. So making sure that that context is preserved, making sure that these audit trails are stored and accessible in a way that you can navigate them and not just view kind of a raw spreadsheet, if you will, is important. Related to that is, and this is definitely a nuanced one that we'll drill into in a second, is the version and change history of a document or of any clinical element. So everything in a system has a lifespan. If you think about something like a medication or a document, you know, there's a life cycle to that medication or document or really anything else. For instance, I might prescribe a medication. I might later on modify the dosage or refill amount for a medication. You can imagine that there could be a very long lifespan to medications that treat you know, chronic illnesses. And so being able to see how that data changed over time is critical from a legal perspective, and indeed it can be important from a clinical perspective. And sometimes that information bubbles up nicely to the top. You know, a lot of EMRs will show you right inside a medication summary how that medication has changed over time. But that same concept applies to essentially every piece of data that these various clinical systems are storing. A problem, a vital, an allergy, obviously a document or a visit note, all of those have the ability in most EMRs to modify them in some way. And generally those systems are keeping the copy of the way it looked before as well as the way that it was changed to. And so just like a contextual audit trail is important to be able to go and navigate to the thing that's the subject of the audit, not just the patient, but the individual piece of information. It's even more important in many ways to be able to see how that data looked like before the change or the access happened versus after. And that is something that is a surprise to a lot of organizations, because if you do a chart export from a lot of different systems, you're not getting that. You're certainly not getting the way this thing looked at a given point in time. You're getting the way it looks right now. If I print a chart in an EMR, it's generally showing me the way the chart looks right now. And that is exactly what you want from a clinical continuity perspective. But if the question is, what did a provider or clinician see at a specific point in time, and made a decision based on that information. That is not necessarily the way it looks right now, the way it looks when the system was actually shut down and archived. And you need to be able to produce essentially a version of that that is accurate to a point in time. And that's where change histories and version histories come in. And then infrequently used and invisible fields. This is another one where if you have access to the original EMR, you can drill in and see metadata that's hidden away from the user interface. And you might wonder, well, why is that important? Why does it matter if there's a property or field somewhere in the database that's used by these EMRs? That if I don't see it, why do I care about it? It clearly wasn't used by a clinician to make a decision because they can't see it. The problem is that these EMRs have a long history, a lot of them, especially ones that are being retired. You know, they might have been used for a decade or more. The software changes over time, and that metadata and that information can affect the way that the information might have been displayed at a given point in the history of the usage of that product. And it can also change the way that the user might have interacted with that information, and if that is accessible to you still, if you still have the database around that you can drill in and see that, you're not missing it. It might be difficult to get to. It might take some actual discovery on your part. But if it's gone entirely, if that system's been completely shut down and retired, you have no chance of being able to reproduce that. And that is problematic. And so any system or any archival strategy should not just store what was seen on the screen and what's in the user interface as of today. It should do its best to store all of the different properties or aspects of these clinical elements that we're archiving. And that can be a difficult one to get your mind wrapped around, especially if you don't have a technical background. And then finally, reference data and ancillary systems. So this is a little bit more obvious. This is especially important in acute environments when you're archiving an acute system, because it's common to have lots of specialized systems feeding data into a primary EMR. And examples are fairly obvious: PACS imaging systems, document management systems, external practice management systems, even paper records. Remember, the scope of the data that we're archiving here is not just electronic. Almost every organization has a big stack of paper somewhere, and depending on a bunch of factors that we'll get into in a minute, that paper information may be required to be preserved just like all of this electronic information, which again can present some pretty unique challenges. So let's go into a couple of these in a little bit more detail so that they're a little bit clearer. So this is a screen from an EMR that will remain unnamed to protect the innocent, I guess, or the guilty, depending on how you look at it. This is a medication viewing screen, kind of a detail screen for a given medication in this EMR. And I've called out a couple of interesting things from the screen. We've got at the bottom there's some related data sets. So this would be information that might not be stored directly on the medication, but it might have been relevant. So annotations is an easy one. If there's a comment or some other kind of textual documentation added by a clinician, that's certainly relevant from a legal and clinical perspective. Education history is interesting. So if you're prescribing a medication that requires some additional education on the part of the patient, the fact that you issued that education to that patient certainly can be legally relevant. So just preserving the fact that they had a med on their med list is certainly not enough in that case. You need to preserve the fact that certain education was provided to that patient. The fields at the top there, the clinical data fields label there, I didn't obviously label every single one of them, but you can see there's a decent amount of information on this detail screen that's more than just the med, maybe a signature, a dosage, and things like that. There's a lot of other ancillary metadata, we call this, that describes that medication, and any archival strategy you're going to implement should preserve all of this and should preserve it as close to the original as possible. Finally, down at the bottom there, we have a version history. So this particular EMR kind of shows you a summary, at least in this version of the EMR, it shows you a summary of how that medication might have changed over time. Now, it's not the full details. You're not seeing how every single one of these properties changed. It's just the ones that the EMR vendor in question felt were important enough to kind of bubble up to the user interface here. And so you look at this and you might say, well, that's probably enough. If I can capture everything that's on the screen here, we should be covered. And unfortunately, that's not necessarily the case, because behind the scenes, if you actually drill into the sort of the technology behind this screen, there are dozens or hundreds of other pieces of information that are relevant to this particular medication. Some are probably not ever going to come up and probably never be relevant from a legal or clinical perspective. You know, they're just things that the system needs to run, that's just things that the software needs to function correctly. But there are other properties that may show how the data might have been displayed in a previous version, which again, given the time nature, the point-in-time nature of legal challenges, that can certainly be important. And then there's other things, like, for instance, there's a has security flag on this particular medication, or there's a property that lets you flag that, and that might say, well, this is something that requires elevated auditing or elevated authorization or whatever that might have been. And none of that information is shown on the screen, at least not in this particular screenshot. So you can imagine if you apply that same idea of having all of this metadata about a particular medication to all of the other types of information in a given clinical system, that we're talking about far more information under the covers than is actually bubbled up in the user interface. It's kind of like an iceberg. You know, you're just seeing that tip of the iceberg, but there's a lot of data behind that that might be required from a legal or clinical perspective down the line, since these systems are at some point gone. You know, they're shut down and retired. So to the point of change history, the previous example had a sort of a mini change history right in the user interface, which is great, and a lot of the elements or a lot of the different types of clinical data in the EMR won't have that, even if they're storing it in the background. Problems is a reasonably good example. Many EMRs show you a problem assessment, and they assume that there's only certain things about that assessment that would change and change according to appropriate workflows. But as we know, not everybody follows the correct workflow when documenting information in a clinical record system. And this is actually an example that we've encountered ourselves helping with an e-discovery request. But essentially what happened was, on the left-hand side there, Dr. Levine added a problem assessment for this patient, saying that they had a heart attack. At some point later, another doctor, Dr. Smith, made a change that probably is not legally or clinically dangerous if you don't know that it happened. In this case, the only thing that really changed was they moved it to a different view. You know, I'm not sure if that's correct or not from a clinical perspective, but they moved it from an active view to a chronic view, and you can see that in kind of the green highlighting. And so the fact that that change happened, if all you had was one or the other of these, it's probably not legally significant. You're probably not exposing yourself in any significant way. However, that third change there, the unsafe change by Dr. Howell at the end, this actually happened. The onset date of this particular heart attack was changed. Why was it changed? Well, it turns out that it was changed because the patient had a second heart attack. So this is a new heart attack. This is a new incidence of this particular problem. It's not that the date of that heart attack was wrong and that it was just updated. It was that this was a second heart attack. So clearly that's not the appropriate workflow in the EMR. But that's what happened. And if all you had was the latest version of this, you'd think they had one heart attack in 2009, when in fact they'd had two heart attacks, one in 2006 and one in 2009. And obviously, from a wide variety of points of view, that's clinically and legally relevant. And this illustrates pretty nicely why making sure that you can see what the chart looked like at a given point in time is critical when you're dealing with an archival strategy. So now that we know roughly the sort of level of fidelity and detail that we need to preserve medical records and ancillary information about care, how long do we need to archive this? This is a slightly easier question, slightly less nuanced. There's still some nuance, but it's a little bit easier to understand and absorb. There's a variety of factors. The patient demographics is a big one. You know, a lot of states have different rules for, in fact, I believe every state has different rules for pediatric patients versus adult patients. So you might have to keep a pediatric patient until the records until they're 21. So that could be 21 years if it was like a perinatal situation and you had a record from when they were a day old. You might have to keep that for 21 more years. It might be 7 years after their 21st birthday is one of the states. There's a wide variety of different rules that apply from a patient demographics point of view. There's historical payers, so generally managed contracts require longer-term archival of data than unmanaged contracts or fee-for-service type contracts. Acute versus ambulatory care is an interesting one. Generally, acute data that's recorded in an acute situation in a hospital, most of the time has to be kept longer than information recorded as part of an ambulatory setting. The state in which a care was delivered matters, so there's federal minimums for some of this, and then there's state minimums that are generally based on the statute of limitations in that state. There are a handful of states that actually have specific regulations about it. The state I'm in, Massachusetts, had specific regulations regarding the duration of time you need to keep some of this data that is not directly related to the statute of limitations. But in general, that's your rule of thumb. The statute of limitations is going to be your starting point for a given state. So it matters because if you're an organization that has that sees patients in multiple states, you have to make a decision about whether or not you're going to standardize on the one that's the longest duration across all of those, or try to do it on a state-by-state basis, and it can get kind of complicated. And then finally, what is the sort of date time that triggers this? What's the trigger point on the clock starting to tick, the time you can get rid of this information? And generally, it's the last time the chart was touched by somebody, whether that's a result coming in, whether that's a visit, or what have you. That's the safest way to do it. Is anytime the last time data in that chart was changed, including a visit, generally, that's the time that the clock starts to tick. And just to be clear, this is not restricting how much data in an individual chart we need to keep. So in other words, if a patient's been seen for a decade and they have a decade worth of data in their chart, and the law says you only need to keep this for 7 years, you're keeping a decade worth of data for 7 years from that point in time. You don't get to say, oh, I only need the last 7 years of data for that patient. It's their complete chart going all the way back to the very first thing you ever did with them, the very first piece of information that was ever recorded in the chart. And that's one of the reasons, by the way, that data migrations are done at the same time or in addition to data archival, is because that is not clinically relevant in most cases. What happened 10 years ago to a patient, a lot of that data is no longer remotely relevant, and so you're not going to bring that over as part of a data migration, whereas from an archival perspective, you got to keep it. And this is just a nice graphic. This is acute data retention periods for various states. One interesting asterisk about all of this is that some states have guidelines for certain types of data that exceed these. And an example of that might be patient registration and scheduling information in acute scenarios. There are a handful of states that actually require you keep that specific subset of a patient's chart forever. For whatever reason. So this is a high level, but it's always important to dig into the very specific details of this, and I believe there's a link in the presentation to take you to good guidelines that are reasonably up to date, but obviously that's when you start to employ your legal teams to figure out exactly what rules apply to you. So our goals for this, from an archival perspective, and at this point this should be fairly clear, are we need to preserve the records with a high fidelity as possible to limit liability from a legal perspective. We want to make sure that we can get to those records as quickly as possible for both legal and clinical continuity scenarios. So while that couple of years of data migration you did into your go-forward EMR probably covers you most of the time, there are still going to be scenarios where a provider or other clinician wants to jump out into an archival solution to pull up data that's older than that was not part of the data migration, either in duration or scope. So both of those scenarios are important. And then obviously the whole point of doing this is to reduce costs, right, or one of the big points of doing this. You could just keep those systems up and running forever, I suppose. That's not inexpensive, and in fact sometimes it's completely infeasible. So you know, we're going to see more of this, but we've already seen some vendors go out of business, and undoubtedly that's going to continue to happen. So what happens 10 years ago, or 10 years from now, when a given EMR vendor does not exist anymore, nobody can provide updates for that software, and now the operating system in which it runs is no longer supported, and you need help. So given the scope of time or the duration of time you need to keep some of these records, simply maintaining read-only or some other kind of licensing deal with the vendor is probably not the best go-forward strategy, and it's almost certainly not the cheapest one. Not to mention the complications in that in terms of, you know, jumping in and having people that understand those systems that can still pull records out of those systems. The fact you'll often have to go and drill into dozens of systems to get the information you need. as a whole, it's just not a good idea. So what's the way that you judge an archival strategy? How do you look at this information and look at a solution and assess whether or not that solution is going to be a good strategy going forward? Well, what we've done is we've come up with what we think are the sort of 5 big properties of a system to look at. Now, obviously, there are other ones, and some will be more important to others for different organizations, but these are the big ones that are pretty universal. So at a high level, what is the cost and duration of getting the data out? How do we get the data out of these systems so we can archive it? How do we visualize that data? So does that, and when I say visualize, I mean a user interface. Can I look at this information? Can I search for a patient? Can I bring up a unified view of that patient's information? Can I export that information? Can I access it clinically and legally? What does that cost? When does that happen? Who does that? And you'll see in a minute that that actually varies dramatically based on the strategy. Data fidelity, this is one I'm trying to sort of drive home a lot, which is the closer the data you're archiving is to the original data from that system, the better, both in quantity and in quality. You want to make sure that the copy of the data you have is as close to the original as you can reasonably get while still fulfilling the rest of these goals here. Accessibility, both from a clinical and a compliance perspective. So interestingly enough, the way that a doctor accesses an archive is probably very different than the way that an HIM or legal team accesses the archive. They've got 2 different goals. The goal of a provider or clinician is to find a specific piece of information or set of information that was archived so that they can make a relevant clinical decision for a patient that they're seeing. And that involves rapid access to a specific patient or a specific portion of a patient's medical record. Whereas from a compliance perspective, one of the big goals is the rapid retrieval of probably lots of information across a subset of a patient population, for instance, all patients seen by a given provider over a particular date range, and then to produce that information in a way that is that makes legal teams happy from a discovery point of view. So is it easy to analyze? Is it easy to see how that data changed over time? Is it easy to access the audit trails for that information? And is it easy to hand off that information to a third party as part of, for instance, an e-discovery scenario? So those are 2 oftentimes opposing goals when it comes to a solution. So let's look at some of the options that we have here. And this is not necessarily an exhaustive list, but this is a high-level list and the ones that are the most common that we've seen. So the first one, hopefully it seems silly to most people, but this is actually very common, is just backing up the databases. It's going in, and hopefully if it's a solution hosted by your organization rather than a vendor-hosted solution, which makes it more complicated, you can just do a database backup. You back up all of the places data is stored. You put it someplace you think is safe, and you hope for the best. And from a legal letter of the law, I guess, that checks the boxes. You preserve the information. Now, the problem is when you need to go access the information, you're almost certainly out of luck. And the longer it's gone since you backed up these systems and hoped for the best, the harder and harder that's going to get to access the information. You're going to need to have people with significant domain expertise in these individual systems, and it gets even more complicated if you have multiple systems that you're archiving to be able to access this. Not only that, there's potential IP issues involved in this, intellectual property issues, where that database and the way that it's shaped and the code that makes up the database is often considered part of the application that you've been paying for all these years, but now you're not paying for it anymore, at least that's the goal. So do you get to keep that database? That is a very gray area, and it's going to depend on the way that that vendor's designed their product and honestly how much they want to push it. So when we approach these things, we try to avoid IP issues that relate to making sort of long-term storage copies of this data in the original format in the original databases. But on the bright side, it's perfect data fidelity. You have everything that was originally there, and it's generally very inexpensive. It's something that you're doing already from a backup point of view. Oh, and just let me go back for a second. The bottom right-hand corner here, this is I actually don't know what the graph is called, but basically this is a way of comparing all 5 points at the same time. So the more of this home base, if you will, the home plate, the more of the home plate that's filled in, the better the solution. So you can see here there's very little of the home plate that's filled in. It's got great implementation for the extraction and the load. It's nice and cheap, and it's built in, and it's got very good data fidelity, but everything else is pretty terrible. The next option is one that's very common, especially with archival solutions that advertise themselves as general purpose. So you can archive clinical data, HR data, time tracking, customer relationship management systems. You can archive anything. So the general purpose archival tools are generally what are called extracted schema stores, which is a fancy way of saying they take the information, the shape of the information out of the database, store it exactly as it was, pull the data out exactly as it was, and then they rely generally on tooling and training and services that they sell in addition to the original product to provide access to that. So you will go through the process of archiving, and the process of the actual extraction of the data is usually pretty easy. They support, Microsoft SQL Server, and they support Oracle, and they support DB2, and they support Cache or what have you. And so they've got connectors to these database vendor platforms that are ignorant of the fact that they're a clinical application or an HR application or what have you. And they'll extract it all verbatim, and then they give you tooling that lets you build user interfaces on top of it. And they might have some prepackaged visualizations, but generally it's up to you, and then they sell you services to help you build it or training to help your internal staff build it. So the pros are obviously it's cheap. From an ETL perspective, the tooling itself is generally not cheap, but because it's actually fairly impressive technology. But the actual extraction of the data is cheap because it doesn't have to know anything about the data, and you've got very good data fidelity. IP restrictions are reduced; it's not quite as bad, but it still may violate some IP depending on how stringent the organization is. And it also requires a lot of work after the fact. You're often in for many, many months or years of user interface implementation, and you generally have to do that for every single system you archive because you need to build UI on top of different data stores. You have to build a UI for Allscripts, you have to build a UI for eClinicalWorks, you have to build a UI for whatever. So it's not a general purpose UI. Model document is essentially a CCD. So this is very common. We take a system, we use a tool provided by the vendor or a custom tool built by a third party to extract the summary information like a CCD or CCDA, and you move it into the archive, and you have some kind of generic viewer on top of it. You can also do this as part of a data migration strategy. So this generally is reasonably inexpensive if it's using built-in tooling, but the big downside is you're losing a ton of information. You don't have version histories. You'll generally be missing entire sets of information, entire areas of information. Documents is a good one if you're not doing a CCDA. And as a result, because you're missing the fidelity of the data and there's inherent mapping involved here, you're going to have poor legal coverage because if a question comes up about a particular data element you don't have, you're simply not going to be able to reproduce it. You don't have the raw information anymore. All you have is that kind of summary modeled document. Similar, but a little bit different here is a non-discrete index document. So that's a fancy way of saying a PDF. Virtually every system has some facility to export a chart as a PDF or some kind of portable document. Many, many different vendors, including Galen years ago, used to produce PDFs as chart summaries that would either be imported into the Go4 EMR and stored in a document management system or put into a dedicated archival solution. OnBase or Documentum or what have you. And this has all of the same problems generally that a CCD does, and that is that you're making choices about what data to put into that PDF, you're converting and changing, combining information to create those chart summaries, and the big downside is that it's difficult to find specific pieces of information in these summary documents from a clinical continuity perspective. And from a legal perspective, you have that document. You don't generally have the ability to produce different documents for different use cases. And most of the time, you want to be able to produce exactly the shape of information for a third party that is required and no more and no less. And if all you have is that summary document after the fact, it ends up being difficult. But the big problem here is data fidelity. It's the fact you're making choices about what to map into that PDF and what to render, and things are going to be left behind. Fully modeled is a very popular mechanism to provide a very EMR-like experience where you have an archival solution that looks and feels like the original application, or at least some flavor of an EMR. So it's great for clinical continuity. I can log in, I can browse patients and find charts and sort and filter and search and do all the things you want to be able to do. And so from a clinical continuity perspective, it's excellent, but the downsides here are actually similar to the downsides for a lot of these other mechanisms, which is in order to facilitate that, they're taking the data out of EMR-X and basically doing a data migration into their archival solution. So they have what they consider the good data model, the one that will match the superset of all of the different EMRs that they advertise being able to archive. But the end result is that they're making choices about how to map that information, what information to keep and what information not to keep. And so if there's a property that they didn't know about, that they weren't anticipating, or they didn't consider was important as part of that extraction process, it's going to be left behind. And so legally, you can have gaps in that archive that are going to be difficult to detect ahead of time unless you have a lot of technical expertise on your side, and could expose you to significant legal issues down the road. On the bright side, the post-ETL cost is very low because you have one user interface that's providing you access to all of this information rather than having to build one custom for each type. And then finally, there's a hybrid of these. And so there's a hybrid modeled extracted schema store. So this is taking the best of the extracted schema stores and then sprinkling on a little bit of the fully modeled one that I was just talking about, where you want to have a unified user interface, one that you can view any source of data, that you can browse them, you can search and filter and sort and export, and you have all of that rich functionality that an EMR does and that other clinical systems do. But at the same time, they're not missing a lot of those properties. They're not making choices about what to keep and what not to keep because of the inherent technology behind the solution. It kind of adapts itself to the shape of the information. So so overall, the big downsides are that these solutions tend to be more expensive. They're more advanced from a technical perspective. They also require significant domain expertise from the extraction point of view. The vendor either has to contract out to a third party, or they themselves have to be able to know all of these different databases. So they can't be ignorant, like the extracted schema store vendors, they can't be ignorant of the type of system they're archiving. They have to know how to get data out of these different systems and know what it looks like and know the shape. And if they don't know that, they can run into the exact same problems that all these other ones do, which is missing information, which is the lack of the fidelity of the data. So this is the summary. I've included this because it's a kind of a cool graph, but it shows you that there are areas that all of these are lacking in. Obviously, the hybrid one seems to be the best across all of these, but it's very expensive, and you'll notice that overall cost is not one of the data points here, for better or for worse. The cost of these solutions are almost always a lot less than the original EMR maintenance fees, which is obviously one of the primary goals here. But there are other properties that are involved that I'll briefly go over that you might want to consider before we get to Q&A. Does the solution you're dealing with support single sign-on or some other EMR integration? So if you're going to be leveraging this in any significant way for clinical continuity, for clinicians jumping into the archive when something wasn't brought forward as part of the data migration, having a single sign-on ability where they can click a button in whatever that EMR is and having it open directly into the chart in question in the archive is a huge win. It's not required, but most clinicians and most clinical users are going to demand very rapid and easy access to these, and not all vendors support that. Vendor contracting is a huge one. This is especially important for archival. It's important for any solution of any kind that you're dealing with from an IT perspective, but especially in archival scenarios. You have to be very careful about things like the custodial relationship. So who answers an e-discovery request? Is it the vendor? Because it shouldn't be. It should be your organization that's handling access to the data, that's handling ROI, that's doing all of that. You choose who gets access and who doesn't. It should never be the vendor. And there should always be an exit clause. So being able to get out of this, if you choose you don't like that vendor, how do you get your data back? Is it accessible to you from a technical perspective? Is it accessible to you from a physical perspective? Obviously, security and data integrity is important. This is the last place this data exists. It's going to be rock solid. Oftentimes, the attack area of this or the risk area of this from a patient record count point of view is greater than any other system in your entire organization. If you're archiving dozens of systems, there could be millions and millions of records in here. And from a security point of view and a liability point of view, that's a huge deal. And then finally, hosting concerns. So where does it live? Is it local or the cloud? If I had done this presentation 2 years ago, it would have all been about the general resistance to the cloud in an archival solution, or in any clinical solution for that matter in healthcare. And then now the scenario is actually the exact opposite. A lot of organizations are moving, when they move EMRs and when they retire old systems, they're actually moving to a hosted solution from the vendor. Every EMR vendor, for the most part, has some kind of hosted managed offering, and the cost savings associated with that can be significant. And if you get rid of your data center, if you get rid of a lot of your IT, you don't want to have this island of clinical data being the last thing in your organization that you have to maintain. So there's cost and there's a pros and cons to both. But this is definitely something that needs to be one of the first things you discuss internally, because not all vendors support both. Some support one or the other. And I believe the next is Q&A.
All right, so, very good.
Right on time. 12:51, not bad.
Quite a presentation there, Robert, and we appreciate that. So we have a few minutes for questions, so if you've got any, please type them into the Q&A box in the right-hand side of your screen and leave the default set to all panelists. Robert, I have one or two I'd like to run by you before we wrap up. First question, what determines the state-by-state requirements for legal health record retention?
So some states have their own specific laws that their legislatures have drawn up, and we can provide some links that outline that for any given state. In general, it's the statute of limitations for that state. So how long can somebody go before they sue you for something, from a non-criminal perspective? So that statute of limitations is what's generally going to define the minimum duration from an archival perspective for the legal health record.
Okay, very good. Next question is, in an e-discovery scenario, do organizations grant access directly to the archival solution, or are records exported and handed off in electronic or paper format?
So it depends on the archival solution, whether or not it supports easy granting of access to a third party. Obviously, if you have database backups, that's not an option. But what we found most of the time is if the system in question has, good kind of role-based access control and user security management and all that good stuff, even in the scenarios where it would support granting access to a third party directly, like a third party legal counsel or any kind of third party really, they're still going to have somebody in their organization go into the solution and produce a chart in a format that can be exported and handed off. So again, that's almost always PDF. Sometimes it'll be a data dump of some kind, like a spreadsheet, or that's usually for practice management related data like claims or transactions or what have you. But that's the most common scenario, is handing it off in a portable format that doesn't require direct access to the archive. And again, that's mostly just risk mitigation. Your goal from a HIPAA perspective is to limit access to the absolute minimum that's necessary, and not every archival solution lets you have particularly fine-grained access into what you grant access to. And so choosing what to export and then handing that off is the safest way to go from a HIPAA perspective.
Very good. Question from the audience. How are items such as break the glass handled in an archive solution?
Again, that depends a lot on the archive solution. I can tell you the correct way to handle it would be to try to mimic the original EMR as much as possible. So for instance, to be able to flag either patients or individual clinical elements or types of elements, for instance, like psych notes or types of test results that might be sensitive, like STD testing, be able to have the archival solution know that those were categorized as having extra security in some way in the original EMR, and bring that forward into the archive, and then have the archive do the same general workflow as the original. So prompt the user with something scary that says there's going to be extra auditing, have that audit trail monitored like any other system that you have in your organization. And then the real question is whether or not you go to the extent of simply preventing access or allowing access but making it scary and making it very obvious that they're being watched. And that's an organizational decision, and it's also one that the vendor itself has to support from a archival solution perspective. But that's in general, you want it to behave as close to the original as you can whenever that's possible from a technology perspective.
Okay, very good. I'm going to sneak one more in here. What's the difference between an audit trail and version histories?
So, and that's nuanced, but basically the audit trail is a list of who did a particular action, edited a note, annotated a result, updated a medication. It's a record of when they did that, who did that, and generally what it was done to and who it was done to. So the medication it was done to or whatever, and the individual patient that it was done to. But that does not necessarily tell you what it looked like before that change happened. So the version histories is exactly the data before and after that change. So what did it look like before that edit occurred, and what did it look like after that edit occurred? And we dove into the reason that that's important, but that nuance is critical because there's lots of archival solutions that can take a raw dump of your audit trails. And there's lots of third-party solutions that handle audit trails, Fair Warning and a bunch of other ones. But they're rarely including that context of what it looked like before and after from a data perspective. And that point-in-time requirement of being able to reproduce a chart at a point in time is why that version history is critical.
All right, very good. Well, that's about all we had time for today. When you close out your WebEx window, if you could take a moment and answer our post-event survey, we'd appreciate it. Regarding continuing education, for those of you who hold the CHIME CHCIO certification, attending our webinars gets you 1 CEU. So let CHIME know you were here, and if you've asked us to do so, we certainly will. If you need a certificate of attendance for another CEU program, you can use the final slide in this deck. You will receive an email when our archive recording has been posted to our YouTube channel. To have us produce a webinar on the topic of your choice, you can contact Nancy Wilcox. You can go to our website to see our upcoming schedule. So once again, I want to thank Robert Downey. I want to thank Galen Healthcare Solutions very much for sponsoring this event. Obviously, very important information that a lot of people have tuned in to get. So thank you, Robert. And I want to thank all our attendees for joining. So with that, everybody have a wonderful day. Thank you.
Thanks, everybody.